All right, let's get started with this explainer on gastroesophageal reflux disease. Today, we're stepping right onto the wards. I'll be approaching this just as a senior medical resident presenting a complex case on teaching rounds to an attending physician, which means you are the attending today. We're going to look closely at the clinical framework, separating true acid-driven reflux from hypersensitivity, and establishing exactly how we make these critical clinical decisions at the bedside.
We will structure our clinical framework today into 4 distinct acts. We'll start with our patient's presentation, move into a pathophysiology deep dive, detail our stepwise assessment and management plan, and finally, lock down the protocols for Barrett's esophagus along with some high-yield clinical pearls.
Let's start with Act 1, our anchor for today's clinical deep dive. A 46-year-old man presenting with months of burning right behind the breastbone.
So, building the history in sequence. Our patient reports these symptoms occurring most nights over the last 6 months. It typically starts after large meals, and it is significantly worse when he lies down at night. He says he frequently tastes sour fluid rising up into his throat. Over-the-counter antacids do give him relief for about an hour, but they never fully resolve the issue. Looking at his risk drivers, he's overweight, eats late at night, drinks alcohol regularly, and is a former smoker. Crucially, his medication list includes a calcium channel blocker for hypertension. We'll get into why that's part of the diagnosis rather than just background noise in a minute. On physical exam, he is overweight, his abdomen is soft with just mild epigastric tenderness, there's no palpable mass or lymphadenopathy, and his oropharynx and lungs are completely clear.
Now, you might be wondering why I'm so confident calling this GERD right off the bat. Why is heartburn plus regurgitation together specific enough to diagnose clinically? Well, the answer is that this highly typical combination of retrosternal burning and a sour taste allows us to confidently make a clinical diagnosis of GERD without immediate invasive testing. This is in sharp contrast to atypical symptoms, things like a chronic dry cough, poorly controlled asthma, laryngitis, or even dental erosions. Those atypical features often require much more diagnostic support before we can definitively blame them on reflux. As the resident presenting this case, my next job is to defend why I am not immediately ordering an endoscopy. And my justification here is the complete absence of the alarm features illustrated on this slide. Our patient explicitly denies dysphagia, odonophagia, weight loss, and vomiting. Plus, there's absolutely no evidence of anemia or GI bleeding, like black stools. Because he completely lacks these specific red flags, we are clinically permitted to move forward with empiric treatment rather than sending him straight to the GI suite.
Let's move into Act 2. Now we need to build the mechanics of this disease from the ground up to understand exactly why our patient is experiencing these symptoms. Let's spend some time on the why behind the presentation. At baseline, the gastroesophageal junction is defended by a highly coordinated 3-part anti-reflux barrier. First, you have the lower esophageal sphincter, which acts as a tonically contracted ring. Second, the crural diaphragm physically pinches the junction from the outside. And third, you have the sharp anatomical angle where the esophagus meets the stomach, known as the angle of His, which creates this natural flap valve effect. When this triad works together, acid stays down, but when it fails, gastric contents wash upward.
Here's a key concept we need to get right. GERD is rarely caused by a permanently blown, floppy sphincter. The dominant mechanism of this disease is actually transient lower esophageal sphincter relaxations. These are brief, highly inappropriate openings of the sphincter that are completely unrelated to swallowing. Basically, every time this inappropriate relaxation happens, gastric contents escape upwards, drastically raising the esophageal acid exposure time.
So, what tips that delicate anatomical balance? Well, raised intra-abdominal pressure from conditions like obesity or pregnancy physically forces contents upward. A hiatal hernia can separate the lower esophageal sphincter from the crural diaphragm, destroying that pinching mechanism we just discussed. Impaired esophageal clearance from weak motility leaves acid just sitting in the esophagus. And very rarely we see true acid hypersecretion, like in Zollinger-Ellison syndrome. Now, mechanically linking these triggers to our 46-year-old patient, we are looking at a perfect storm. His supine posture and late meals mean gravity isn't helping clear the acid at night. Fatty foods, regular alcohol, and his smoking history pharmacologically relax the sphincter. And remember that calcium channel blocker I highlighted? It's a direct smooth muscle relaxant, which includes the lower esophageal sphincter. That proves exactly why his medication list is an active part of this diagnosis.
We really cannot ignore the stakes here. Chronic, unchecked acid injury doesn't just cause discomfort. It steadily progresses from reflux esophagitis, where mucosal erosions and ulcers form, into a vicious cycle of injury and healing.
Over time, that repeated healing creates scarring, which can form a peptic stricture. This leads to progressive solid dysphagia, where patients literally feel food getting stuck in their chest. The squamous epithelium is also at risk of being replaced by columnar intestinal-type mucosa in Barrett's metaplasia, which we'll cover shortly. This progression is exactly why we treat aggressively.
With the pathophysiology established, we move into Act 3. As the resident, I need to answer the attending's next obvious question. What is the precise treatment plan for the 46-year-old man in front of us? For a patient with typical symptoms and no alarm features, our standard of care is an empiric first-line trial with a proton pump inhibitor, rather than testing first. This is widely known as the PPI test. If his symptoms resolve on acid suppression, it strongly supports our clinical diagnosis. However, we have to be clear about what this test does not establish. It tells us the symptoms respond to acid suppression, sure, but it absolutely cannot tell us if the cellular architecture of the lower esophagus is already changing.
Let's walk up the treatment ladder. Step 1 is always lifestyle. Counseling him on weight loss, shifting to earlier meals, elevating the head of his bed, and aggressively encouraging him to stop tobacco. Step 2 is acid suppression. We start the PPI low and up-titrate to twice daily if needed. Histamine 2 blockers can fit in here for breakthrough symptoms, and vonoprazan is an excellent emerging therapy to keep in mind. The crucial rule here is that we must give the patient a fair trial of at least 8 weeks at the maximum dose before officially calling the therapy a failure.
But let's say 8 weeks go by, he comes back to the clinic, and he is still complaining of burning. Before we jump to endless, blind PPI escalation, we have to ask ourselves, what are we missing if the patient isn't getting better?
This is where ambulatory 24-hour pH and impedance testing comes into play. It is absolutely required to separate true acid-driven disease from other phenotypes. If acid exposure is abnormal and symptoms correlate, that's non-erosive reflux disease, or NERD. But what if the acid exposure is totally normal? Well, if their symptoms still track precisely with physiological, non-acid reflux events, they have reflux hypersensitivity. And if acid exposure is normal and there is zero correlation between reflux events and their pain, that is functional heartburn.
This distinction changes everything about our management. Confirmed acid-driven reflux, NERD, responds to acid suppression and opens the door to surgical options, like a hiatal hernia repair, a fundoplication, or magnetic LES augmentation devices. Note that esophageal manometry is strictly required before any of those surgeries to rule out severe motility disorders. On the flip side, the non-acid phenotypes, hypersensitivity and functional heartburn, need an entirely different approach. You have to stop the endless PPI escalation. Instead, you pivot to neuromodulators to treat the hypersensitive nerves. We're talking low-dose tricyclic antidepressants, SSRIs, SNRIs, or trazodone.
For our final act, we must lock down the disposition, teaching pearls, and the most critical long-term complication of this disease, Barrett's esophagus.
When acid continually washes over the lower esophagus, the body attempts to protect itself through cellular adaptation. Barrett's metaplasia is the replacement of the normal pink squamous epithelium with this salmon-colored columnar intestinal-type mucosa just above the gastroesophageal junction. While this new tissue handles the acid better, it acts as a dangerous pre-malignant lesion that significantly raises the patient's risk of esophageal adenocarcinoma. So who actually warrants a one-time screening endoscopy to look for this? It's indicated for patients with chronic reflux, meaning more than 5 years, or frequent weekly symptoms, plus multiple risk factors. Those include being over age 50, male sex, white race, obesity, a smoking history, and a family history of Barrett's or esophageal cancer. Look at where our patient sits. He's 46, so slightly under 50, but he has frequent weekly reflux, male sex, obesity, and a smoking history. He is right at that threshold where a one-time screening endoscopy is absolutely warranted to establish his baseline. If Barrett's is discovered during that scope, we strictly follow these surveillance tiers based on the level of dysplasia. For no dysplasia, we manage them with a repeat endoscopy every 3 to 5 years while keeping them on a PPI. If low-grade dysplasia is found, we increase the surveillance frequency to 6 and 12 months, then yearly, and we consider endoscopic ablation. And if high-grade dysplasia is present, we move straight to endoscopic eradication therapy before malignancy can develop. Bringing it all back to our 46-year-old man at the bedside, here is my final assessment and plan. Assessment. 46-year-old man presenting with typical GERD and zero alarm features driven by obesity, late meals, and calcium channel blocker use. Plan. Initiate aggressive lifestyle modifications, specifically focusing on weight loss and meal timing, paired with an 8-week empiric PPI trial. We will reassess his symptoms in clinic in 8 weeks.
And if he fails therapy or develops alarm features, we will proceed to endoscopy.
As we wrap up this presentation, I want to leave you with a few high-yield clinical pearls. First, avoid the reflex to endlessly escalate PPI doses without objective ambulatory pH evidence of an acid-driven failure. Second, do not miss the crucial alarm features that override empiric trials and demand an immediate scope. Third, be incredibly careful calling atypical symptoms GERD without diagnostic support. And lastly, never forget to screen for Barrett's in your high-risk demographic patients.
I'll leave you with this provocative diagnostic thought to challenge how you assess your next refractory case on the wards. If you've maximized acid blockers and the burning still persists, are you truly treating the acid, or do you need to pivot to treating the nerves? Understanding that distinction is what separates good clinicians from great ones. I hope this framework profoundly sharpens your clinical approach to GERD. Thanks for exploring this case with me on this explainer, and I'll see you on the next round.